Hello everyone, thank you for joining us today. My name is Luke, I'm one of the Education Directors at SUPTA, and this week we're focusing on ophthalmology and we're excited to have you all with us. Today I'm joined by Paul, who will guide you through today's topic of red eye. Paul is a third year medical student from the University of Warwick. To make these sessions as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form. If you complete this, you'll receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and pass the MRCS. Additionally, this session is being recorded. The recording and slides will be shared on our medal page a couple of hours after the session, so be sure to keep an eye out for that. We're also excited to share that an exclusive question bank and other resources will be made available on our learning portal, so be sure to check out our website for access. If you create a free membership account with us, you'll automatically receive a discount code with 10% off the Geeky Medics Anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all of our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code that we'll provide. The more sessions you attend, the higher your chances of winning. So be sure to stay until the end of today's session and attend as many of our other sessions as well. And finally, before we begin, we'd just like to thank our partners, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I will hand you over to Paul.
Cheers, thanks Luke. Hi everyone, as Luke said, my name is Paul. As you can probably hear, I'm a bit sick at the moment. I'm on PED, so I think I've caught it from one of them. But I'm going to try my best to push through and make it as engaging as possible, even though I don't feel very well. So today, I'm going to do a session on ophthalmology, specifically presentations of red eye. And before I was a medical student, as Luke said, I'm third year at Warwick. Before I was a medical student, I was a teacher, chemistry teacher. So hopefully it won't be terrible. But what I like to do, I've done a fair amount of peer teaching in the past for medicine. So rather than go through loads of granular level detail, stuff that you can get from more reliable sources, I want to teach like frameworks and approaches to understanding presentations. So that's what we're going to focus on: how to compartmentalize elements of the eye anatomy, eye presentations, so that you can navigate conditions a little bit more easily. So that'll be the general approach. So we'll start with some anatomy, because the eye is quite a nice little anatomical unit, and you can divide conditions based on which anatomical structures they affect. So that's a nice way to think about eye pathology. And then we can talk about different presentations that you might get alongside a red eye, which we'll talk about as well. So first thing is, this is the eye, and the first thing to understand is that there's anatomical divisions. So we can break this quite complex, intricate structure up into some broad regions and try and then as we get exposed to different pathologies, we meet different patients with these pathologies, we read about these different pathologies, you can put them roughly into the compartment, the division that they affect. So the four divisions, 2 of them are formal, proper anatomical ones, and then the other 2 I think I've just sort of made up. But we've got the external eye, the anterior segment, the posterior segment, and then the orbit, which is all the surrounding structures. So so the anterior segment and the posterior segment, they're formal anatomical divisions of the eye. They're not to be confused with the anterior and the posterior chamber, which are further divisions of the anterior segment. So the anterior segment is broken down confusingly into an anterior and posterior segment. But so when a patient presents with a red eye or any eye pathology, you can start to think about where is this pathology hitting, where am I focusing on? The external eye, you've got things like the eyelid, so you might look at pathologies like chalazion or a stye, or it might be a palsy of the orbicularis oculi, cranial nerve 7, so that the muscle that controls the movement of the eyelid. Also smaller muscles that control movement of the eyelid, like the levator pupillae superialis, things like this. So you've got the external eye, And then you've got the anterior segment. Now, the anterior segment is one of the main focuses of today. We're going to have a big look at, like, a deep dive into the anterior segment, because there's lots of pathologies that are associated with it. There's lots of pathologies that are associated with it that can cause a red eye, and it's quite an intricate piece of anatomy. You know, it's quite detailed. So this will be mainly where our focus is anatomically. So you've got things like, you know, acute angle glaucoma. We're going to have a look at anterior uveitis. Then you've got the posterior segment. So, you know, the most well-known part of the posterior segment is probably the retina. So we have got a little bit of retinal pathology in there, but then when you know, talking about pathologies that affect the retina, the presentation would more be like something that's affecting vision. And then you've got, so that's the posterior segment. We'll go into it in a little bit more detail. And then you've got the surrounding structures. So you've got this orbital fat that you can see. You've got cranial nerve 2. You've got all the bones that make up the orbit. You've got the extraocular muscles, so the muscles that are innervated by cranial nerves 3, 4, and 6 that control the movement of the eye. That's all we'll think about as like extraocular things, so orbital things. So as you go through pathologies related to the eye, it's nice to think about, you know, where am I, and how worried should I be based on where the pathology is affecting. Generally speaking, you know, pathologies that affect the external eye, affect the eyelid, things like chalazion or a sty, are less concerning than things that might affect the posterior segment. So things that are affecting the retina, and things that are affecting the orbit as well, because they can compress the optic nerve. So yeah, so it's a nice way to start thinking about where pathology. It's a nice way to structure pathologies in your mind. So yeah, just some things that are in each one. So there's a typo already. Eyelids, eyelashes, conjunctiva, which is this layer here. It actually doesn't go over the lens, but we'll talk about that later. Lacrimal apparatus, etc., etc. And you've got the muscles that control the shape of the eye: apicularis oculi, levator pupillary superiorlis. Anterior segment, there's loads going on in the anterior segment, so we'll talk about all of that. We'll show it in a little bit more detail, because that's probably the most complicated part anatomically. So as I said, anterior segment, confusingly, is divided into the anterior chamber and the posterior chamber. So don't confuse those with the anterior and posterior segments. Iris, pupil, lens, and then you've got the structures that control the flow of aqueous humour. So we'll talk about those as well. Posterior segment, vitreous body, retina, obviously very important. Parts of the retina, including the macula, fovea, optic disc, optic nerve, the choroid and the sclera. I'll go through those parts as well. And then you've got the orbit. So orbital bones that are like the housing, the case that the eye sits in. Orbital fat, extraocular muscles that we spoke about, lacrimal gland, optic nerve, obviously is still going through this orbit as well. So good. So yeah, so as we go through things, we're as I said, mainly interested in the anterior segment, but we'll talk a little bit about the others as well. So the eyeball itself, so we're just talking about the eyeball itself before we focus in on the anterior segment. You can think of the eyeball as a layered structure, and there's 3 layers to it, 3 main layers. So most superficial, you have the sclera, which is sort of your fibrous case of the eyeball. Okay, so it holds everything in the correct shape, and supports everything and protects everything. So this is your sclera, and there's only really 2 parts to the sclera. You've got the opaque part, which goes around all the way around the back of the eye, and this is the sclera that you can see here. And then you've got it goes transparent where you've got the cornea just here. So that's the outermost layer. Obviously it's for collecting light and for some protection and structure. And then if you look here, you've got what's labelled as the choroid here. This is your vascular network. Okay, so it's called the uvea. The entire network is called the uvea. What it is the choroid, which is this vascular network around the posterior and lateral aspect of the eye, and then that turns into the ciliary body, which is here. We'll talk a fair bit about the ciliary body, and then into the iris. Okay, so that's collectively it's called the uvea: choroid, ciliary body, and iris. Choroid, ciliary body, which is here, which controls the shape of the lens, and then you're onto the iris just here. So that's sort of In the back, that's sort of vascular, and then it turns into muscular towards the top end. And we'll go into all the details about the anterior chamber here. And then you've got, so that's mainly vascular, so fibrous, vascular, and then you've got the retina, obviously very, very important, and all the different parts of the retina and the vasculature of the retina. So that's your sort of photoreceptor zone. That's what the main function of the eye, to perceive light. That's where all the business happens. So you've got all your photoreceptors on there. So that's the layered structure of the eye. So you've got these broad anatomical divisions where you can place pathologies, and then the structure of the eyeball itself, fibrous, vascular, photoreceptor sort of thing. Good. Okay, so now for the busy part of the eye. As we said, the eyeball itself can be divided into this anterior segment and this posterior segment. We're going to look in more detail in this anterior segment because it's quite busy. Anatomically, it's quite intricate, and there's a fair few pathologies that can be associated with that anterior segment. So yeah, here's a zoomed in part of the anterior segment, and the anterior segment is defined as what's in front of the lens, and your posterior segment is behind the lens. So you can see just when we zoom in, anatomically, it's very busy. So these are two chambers. So not to be confused, anterior and posterior chamber are divisions of the anterior segment. So the anterior chamber is what's in front of our iris, and the posterior chamber is what's between the lens and the iris. So the posterior chamber is actually quite small, and the anterior chamber is between the iris and the cornea. Okay, so we'll look at the anterior chamber first. So you've got the cornea, okay, which is part of the sclera, scleral layer. It's just where the sclera turns transparent, so we can allow light in. So we've got the cornea, and then we've got the iris, which is the coloured part of your eye, and it's also muscular, which we'll talk about in a second. Oh, no, we'll talk about right now. So you've got your cornea, you've got your iris, and then the opening in the iris is your pupil. So the size of your pupil obviously has to be autonomically controlled. So we've got two muscles here. So this is, remember the layers, this is an extension of your uvea, the sort of vascular turned muscular layer. So this is your ciliary body, and then it turns into the iris, which is muscular. And there's two muscles that control the size of the iris. We've got the pupillary sphincter, sphincter pupillae. So that's, as its name suggests, a sphincter. It's like a circular ring of muscle. So that's responsible for contracting the iris and making it smaller. And the pupillary dilator, or the I guess there's a more Latin name, that's more longitudinal muscles, and that's obviously responsible for dilating the pupil. So in the iris here, to control the size of the pupil, we've got these two muscles which are autonomically controlled. And we'll go on, we'll talk about how those feed into the treatments for certain pathologies as well. So that's the anterior chamber, cornea, iris, and then you've got within the iris, you've got these muscular layers to control the size of the pupil. And then if we go through the pupil itself, then we get into the posterior chamber, which is between the lens and the iris. Okay, very small, as you can see here. So that's our pupil. And then we've got the lens, which is used to refract light and control how the light hits our retina. So it's used for focusing, part of the accommodation reflex. So this is our lens here, and we can change the shape of our lens using this ciliary muscle here and these suspensory ligaments. Okay, so the ciliary body or ciliary muscle, it pulls on the lens using the suspensory ligaments to change the shape of that lens. And then in terms of aqueous humour, so you can see here, this is like a lateral view of the anterior chamber. Vitreous humour in the posterior segment. In the anterior segment, which is everything in front of the lens, we have aqueous humour. And obviously, your glaucoma is related to how this aqueous humour can flow or it can't flow. So this quite intricate bit of anatomy is to do with how aqueous humour flows. So this here, what we're interested in, is called the iridocorneal angle. So it's the angle between the cornea, and the iris, hence iridocorneal angle. And that's very important for your acute closed angle glaucoma. So we'll talk about that. So the flow of aqueous humour, it starts on the ciliary body, which is the muscle that controls the shape of the lens. On the ciliary body, we have this ciliary epithelium, and that's where we produce our aqueous humour. So the aqueous humour is going to come out of the ciliary epithelium. It's going to flow through the posterior chamber, through the pupil, and into the anterior chamber. And then it needs to be recycled. So you've got this continuous flow, ciliary epithelium, through the posterior chamber, through the pupil, into the anterior chamber, and then into this ciliary epithelium, into this trabecular meshwork. So you can imagine that like a little sieve. So this trabecular meshwork here, in the iridocorneal angle, that's where the aqueous humour is sucked up and it's filtered into the canal of Schlemm. And then I think it goes probably into vascular. You can see it goes into the vascular network. I think it's probably into veins. Yeah, so this is the flow of aqueous humour, and there's a continuous flow of aqueous humour. And if we have anything that disrupts that flow of aqueous humour, so we stop it being able to flow, particularly the pathologies are related to it being able to drain, we'll still continuously produce it, and then you'll get a buildup of aqueous humour, and that's what's going to increase intraocular pressure. So typically, usually pathologies are related to this drainage. And then just so you can see it in profile here, here's our ciliary epithelium, produces our aqueous humour through posterior chamber, through the pupil, into the anterior chamber, through the trabecular meshwork, and into the canal of Schlemm. That's the flow. Posterior chamber, anterior chamber, went through all that. Okay, so that's all of the, it's not hugely detailed. You've got much more reliable anatomical sources than me. But it's just a way to think about the structures of the eye, because it's quite, it's quite an intricate piece of anatomy. We can divide it into those four sort of broad anatomical areas: external eye, anterior segment, posterior segment, and then the sort of extraocular space or the orbit. And then you've got the layers. You've got sort of a fibrous layer on the outside, then a vascular time muscular layer, and then you have your photoreceptor layer, which is your retina, most deep. And then you've got, just because we're going to deal with some pathologies that relate to this area, anterior segment, very busy, but everything's got its function, everything makes sense. And yeah, I love this picture. I think it's really nice because you've got all of the main bits that you can see. And good. And yeah, so we're going to go through some pathologies, and we'll come back to this anatomy. I think anatomically, so when you're talking about clinical presentations, or you're trying to think about clinical presentations, with the eye, I think is most helpful. In some conditions, it might be useful to think about, autoimmune causes, infective causes, malignant causes of pathologies or presentations. The eye, anatomically, is a nice way to approach it. So again, just as I said before, you can think about is this, when someone presents with a certain pathology, is this affecting the external eye, or is it going a little bit deeper and affecting that anterior segment, or the flow of aqueous humour, or something to do with how the pupil's functioning, or how the lens is accommodating? Is it something related to the posterior segment? So is it a pathology that's affecting the retina, so like something diabetic or hypertensive? Is it the vasculature that feeds the retina, so the retinal artery or the retinal vein? Is it affecting the optic nerve itself? So you're thinking about posterior segment. I think you've got changes in vision after this, so that'll be a lot of focus. Well, I should have thought so. There'd be a lot of focus on the posterior segment, although you can get some changes in vision with the anterior segment as well. Or is it pathology that's affecting the orbit, so the surrounding extraocular muscles, or the orbital fat, or the bones of the orbit? So whenever I see a presentation, I like to put it into, think about how deep in the eye we're going, what structures is it affecting? And then obviously you've got different presentations. This was broadly about red eye, but I've got a little bit off piece, but whatever. So you can think about the presenting complaint. So what exactly is the complaint related to the eye? And I think of the presenting complaint more as a gauge of severity. So when you're trying to compartmentalise pathologies, this will give you a location. And this I'd like to think of as like kind of severity. So are they complaining of any swelling around the eye, any lesions to the eye? So is it lesions to the surrounding structures, or is it lesions to the eyeball itself? Any discharge from the eye, so you might think to more infective causes. Any dryness, might be a sign of some autoimmune related conditions. Red eye, lots of causes of red eye, pretty harmless, but some are very severe, as we'll go through. Are there any changes to the pupil? So the shape of the pupil, or the ability of the pupil to respond to light. Is there any pain associated? So is the eyeball just painful in and of itself? Is the eyeball pain? Is the pain around the eye? Is the eyeball painful when you move it? And then vision, obviously very, very important. Is there any changes to vision? Is there a clouding of vision? Or is there a loss of vision? Is there a curtain coming down? Can all help you pin down a pathology. Now, just a general rule of thumb. I don't know what year you're all in, so forgive me if I'm teaching you to suck eggs, but it's nice. When it comes to the eyes, obviously you don't want to mess around. You want to be able to spot the severe from the harmless pretty proficiently. So just a general rule of thumb, and you'll see this in the presentations. These three in particular. So if you're seeing changes to the shape of the pupil or the accommodation of the pupil, or if the patient's reporting severe pain, or there's changes to vision, that's when you start thinking, shit, this is quite severe. So they're the sort of, just generally speaking, when someone's presenting, these are the sort of markers of how severe the condition is and how quickly you have to respond. Dryness, things like dryness and swelling, depending on exactly what kind of swelling, or some discharge, typically aren't emergencies, although obviously they can be. But any changes to the pupil, any severe pain, or any changes to vision, you're thinking this is something quite severe and I need to respond well to this, and almost always escalate. So we're going to go through some presentations, and for the most part I pick presentations that you just want to be able to spot to try and, once we get GMC licenses, so that we can keep them GMC numbers. So we'll just do a question on a particular presentation, and then we'll talk about two conditions which you should be able to differentiate between, or you'd want to be able to differentiate between. So Luke, this is the first poll question. I'll just give you a little bit of time to have a read of it. When you're reading through, think, in the presentation, is there anything that's particularly alarming here that would make me worry? And then, answer the question.
Just coming in now. I'll give it 10 seconds.
Right.
We had a question in the meantime. Someone just wanted to clarify. So it's the aqueous humour moving from posterior to anterior chamber, or is it the vitreous as well?
No, the vitreous is in the posterior segment. It's the aqueous humour that moves from the posterior segment to the anterior segment.
So with the poll, 66%. So most going for IV acetolamide, 75%.
Yeah. Okay. Well, what was the second most popular option?
Oral pred.
Okay. Cool. So, I don't know. I don't know if does anyone want to shout out the diagnosis? Anyone?
I'll let you know.
They've got microphones, right? They can speak, or do they?
I don't know if they've got microphones. They can send a message to the chat though.
Okay. All right. Well, in the meantime, I'll carry on talking. So, emergency department. So, this immediately, I'm thinking these are red flags, right? Severe right eye pain. So, pain, red flag. Nausea and vomiting. Guess also. Red eye, mid-dilated fixed pupil. So that's worrying if the pupil is not accommodating or changing size. Cloudy cornea. Changes to visual acuity. So this one's just absolutely reeks of an emergency.
Someone's giving an answer. Acute angle closure glaucoma.
Yeah, lovely, very good, perfect, well done, whoever that was. So this is okay. Oral, so it's usually IV. Sorry, I should have changed that. So in acute angle glaucoma, we'll go through the pathophysiology of it. But the main problem you've got is to do with that drainage of aqueous humour. So the trabecular meshwork is obstructed and the humour isn't flowing. So you're continuously producing humour, and that builds up pressure in the eye. So you're building up intraocular pressure. So the way this drug works is to stop the production of aqueous humour, or to reduce the production of aqueous humour. Okay, so carbonic anhydrase inhibitor decreases aqueous humour production, so you can decrease that build-up of intraocular pressure. If you build up intraocular pressure, one of the main things that's going to happen is you're going to compress the optic nerve and cause ischemia to the optic nerve and therefore the retina. So it's an emergency, you need to deal with it quite quickly, so it should be IV. Okay, so these are two very similar presentations. So on the left here, we've got a patient presenting with pain. So these are two both, usually, some of them I've got an emergency one and a non-emergency one. Both of these are quite, emergency sort of things. So here we've got pain, that's worrying, photophobia, blurred vision, redness, obviously you can see quite injected, sclera there, or conjunctiva, and then a small irregular pupil. So you can see the irregularity of the pupil there. And over here we've got a very similar presentation, severe eye pain, blurred vision, headache, redness, mid-dilated fixed pupil, so the pupil isn't responding to light, and a cloudy cornea. So the only thing that really differentiate these two is that this pupil is fixed, and then this pupil is irregular and relatively small. Though that looks quite big to me. And here's severe pain, and here's just pain. But both of these are quite worrying presentations, and they've got some red flags there. So changes to vision, pupil not responding to light properly, and pain, all worrying features. So this one on the left is anterior uveitis, and the one on the right is our acute angle closure glaucoma, which is the presentation that we just saw in that question. So we'll go through the anterior uveitis first. And I guess the most distinct feature of this, when you're differentiating between these two, is this irregular pupil. So typically this presentation is associated with autoimmune diseases. So it can be idiopathic, but it's commonly associated with autoimmune diseases because it's an inflammation of the uveal tract. So if you think about those three layers of the eye, the uvea is the vascular network. So it's that middle layer between the sclera and the retina. It's the vascular network, and this anterior is specifically as that vascular network turns into the ciliary body. Sorry, I've got it down here, that'll make it easier. So that vascular network turns into the ciliary body, which is that muscle there that controls the accommodation of the lens, the ciliary body, and the iris. So what you've got is inflammation in the ciliary body and this iris, which is also muscular as well. So it's commonly associated, it's an inflammation of those structures associated with HLA-B27, which is like your ankylosing spondylitis, rheumatoid arthritis, psoriatic arthritis, those sort of things. So obviously pay attention to any autoimmune conditions in the patient history. It's an inflammation. So our investigations is slit lamp exam. So this is where they look through a certain type of light or a certain type of visual thing, I don't know. And you're looking for signs of this inflammation. So cells and flare. Flare is something to do with how the inflammatory cells respond to light. I don't know about it too well. Hyperpion is, I think you see it in extreme cases, is where you'll see like a little pooling of this yellow fluid in the anterior chamber, and that's a collection of white cells which have collected there from the inflammation. It's quite weird looking if you have a look at it online. So that's how we would investigate this sort of inflammatory condition of the anterior uveal tract. And it's inflammatory, so the main response we're going to have, the main thing we want to do is give some steroids to try and reduce the inflammation. You can also see these cycloplegics here, which was an option in the previous question. So the cycloplegics, what they can do is they can paralyze the ciliary muscle to try and relieve. I think they also act on the dilator as well to try and relieve the tension in those muscular structures because they're inflamed, and if they're contracting as well, that's going to cause a lot of pain. So you can use cycloplegics to try and release the tension in those muscles and reduce the pain. It can also cause, you can see here, glaucoma, so it can also cause a picture like this, because if you think about that iridocorneal angle, And if these muscular structures are inflamed, they can compress against the trabecular meshwork and prevent the flow of aqueous humour. The posterior syntachiae is when if your iris is inflamed, it can, when you get inflammation, you can get adhesions between the iris and the cornea. So that's what those are. But hopefully you respond to this quickly enough so that you don't see any of these complications. And it needs an urgent referral to ophthalmology, given the damage it can have to the pupil, it can have to the cornea, etc., etc. Good. Okay, and the acute angle closure glaucoma. So this is all related to the anterior chamber and the flow of this aqueous humour. What happens is that you've got aqueous humour flowing through here, and then this iridocorneal angle gets closed. Okay, so sudden rise, and that means the aqueous humour is still being produced, but it's not draining away. So it builds up and it builds up. That increases intraocular pressure, and obviously then that can compress the optic nerve, cause ischemia to the optic nerve, and you can start to lose vision. So usually mechanical obstruction to the trabecular meshwork associated with age, long-sightedness, certain medications, family history, Asian ethnicity. And given that here we're not investigating an inflammation necessarily, we want to diagnose based on this raised intraocular pressure. So that's what motivates your investigations. Tonometry, where you can assess the intraocular pressure to try and establish whether there's a prevention to the flow of aqueous humour. Again, given that it's an obstruction to that flow, the management is based on trying to re-establish that flow of aqueous humour. So you've got two places you can target, right? If the aqueous humour is flowing out but being obstructed, we can try and relieve the obstruction to help it drain away, but we can also try and reduce its production. So you can target in two places. Again, this is where the anatomical divisions come in really handy. Acetylzolamide is to reduce the production of aqueous humour from the ciliary epithelium. So whilst it's not draining away, we don't want any more produced, so we can try and reduce that production using that carbonic anhydrase inhibitor. I think that's what whatever that class of drug was. The pilocarpine, that was more related to targeting this obstruction. So what's that's going to act on is the ciliary body, and also the constrictor pupillae, or the pupillary sphincter. So what we want to do in this case, rather than relaxing these muscles, we want to try and stretch them out. Okay, because you can imagine if these muscles are contracted, so if the iris is, the dilator muscle is contracted for the iris, it's going to push against this trabecular meshwork. Whereas if we have a pull from the sphincter and we have a pull from the ciliary body, we can flatten out that iris and move it away from the trabecular meshwork and allow the aqueous humour to flow a bit more easily. So that's what the pilocarpine is for. It's going to cause the sphincter pupillae to constrict, to flatten out this dilator pupillae, and also the ciliary body as well. The timolol is a beta blocker that also reduces the production of aqueous humour, so that's targeting the production bit. And then laser iridotomy with alternator, going back again. That's using lasers to try and open up the trabecular meshwork to try and allow the flow of aqueous humour back out. So very anatomical. We're either going to when you've got this obstruction to flow, you're either going to target the production, or you're going to target the drainage, or you're going to target them both to try and relieve it. Okay, emergency, refer to ophthalmology. Optic nerve damage from the build-up of intraocular pressure, compression of the nerve, ischemia, blah blah blah. Good. So that's the first one. How are we doing for time? Okay, good. Next question.
Yeah, votes coming in, mostly going for scleritis.
Good.
1 or 2 per episcleritis.
Okay, cool. So yeah, good. So perfect. This is the next. Well, I'll show you pictures of both. So scleritis is the correct answer. So this is scleritis is going to cause a severe sort of boring eye pain. It commonly radiates to the jaw and to the face. It's worse when you move the eye. You get this characteristic. I think it's quite rare to see, to be honest, but you get this characteristic sort of bluish hue to the sclera. And it's commonly associated with autoimmune disease, so like rheumatoid arthritis. So there's some red flags in this one. Severe eye pain makes you worry. It's worse on movement. It radiates to a jaw, and then you've got this and affecting the vision as well. So that makes you think, okay, this is an emergency condition. We'll focus on differentiating scleritis and episcleritis. Episcleritis, as the name suggests, is inflammation in the sclera, which is more superficial, so it's typically painless and self-resolving. So we'll go through that. Good. Yeah. So inflammation of the sclera. So if you think about, I don't want to go all the way back really, but okay, if you think about our layers, it's the outermost layer of our eyeball. So again, we need to think about the anatomical division. So here we're thinking about the layers. It's an inflammation of that sclera. If it's episcleritis, it's sort of the outer part of the sclera. If it's scleritis, it's more towards that vascular network of the uvea. Okay, intense eye pain, worse on movement, is a characteristic sign of scleritis. Episcleritis, typically painless. I'll go through this. Redness with a bluish hue. So here's the two. Obviously, pretty similar in presentation. You've got this injected sclera here. It's a bit redder over here. You can't really see any blue hue, except maybe there, a bit blue. But this is an emergency. This is relatively innocuous. So again, you can tell it's an emergency because you've got severe pain, redness of the eye, photophobia, effect on the vision. And here you've got some mild discomfort, if any discomfort at all, some redness of the eye, no vision loss, no pain or tenderness. So it's mainly in the history that you're going to be able to distinguish between scleritis and episcleritis. So your scleritis is an inflammation of the sclera. So that's this outermost layer here of the eyeball. And again, associated with autoimmune conditions, RA, rheumatoid and SLE. So given that, then we're going to focus on targeting that inflammation. So you can start, first line is NSAIDs to try and reduce the inflammation, steroids, and then if it's an intractable condition, a case, and it's not responding to NSAIDs or steroids, then you look at some immunosuppression therapy. So complications, vision loss, thinning of the sclera, globe perforation, which goes hand in hand with thinning of the sclera, and this secondary glaucoma. And it always requires an ophthalmology referral. Episcleritis, it's benign, self-limiting inflammation of the very outer part of the sclera. So we're not too concerned about it affecting the inner structures. Typically, no effect on vision because it's very superficial. No pain, no tenderness, maybe some mild discomfort, but definitely not pain on the scale that you see it with scleritis. Management. It's typically supportive. You don't really need a huge amount. They usually resolve on their own. You can give some just over-the-counter NSAIDs or move to steroids. Of course, short course of steroids if it's symptomatic or if it's persistent. As I said, rare. Generally self-limiting, and only if you get it a lot do you have to refer. But usually it'll just sort itself out. So scleritis, episcleritis. Big thing here is the pain. Pain is almost always an indicator. Severe pain is almost always an indicator of emergency or a severe condition in ophthalmology. So pain is great. Lovely. Next one. Scores on the draws.
The split between lateral canthotomy and cantholysis and intravitreal steroids.
Okay.
CNE.
Okay, so that's the right question. Okay, so this one, what are the red flags? This one, what are the alarming things? So blunt trauma to the right eye. That doesn't sound good. Pain, we've got the pain there, blurred vision, and reduced eye movement. So not necessarily pain on movement, although I imagine there will be, but something's restricting the movement of the eye there. So you can think of, if you were to divide it anatomically, it might be some kind of something related to the nerves that innervate the muscles, the extraocular muscles that move the eye, or it might be an actual physical obstruction to the movement of the eye. Examination feels proptosis, so that's bulging of the eye forward. We're affecting vision there, that's alarming. And then relative afferent pupillary defect, so your pupil's not, it's where you swing the light, and it should constrict when the light gets shone in that the affected eye, but it actually dilates because of the amount of light that's getting through, or something along those lines. But the take-home message is that we're seeing a change in how the pupil's responding to light. So there's a lot of things to be worried about there. So the actual diagnosis, given the history of trauma, and particularly the reduced eye movement gives this one away, alongside the trauma, is that it's retrobulbar bleed. So it's got two names, orbital compartment syndrome or retrobulbar bleed. Both are quite literally named. So a retrobulbar bleed is a bleed behind the eyeball. And so this is to do, if you're thinking about those anatomical regions, this is related to the orbit. So you've got a bleed in the orbit. As you produce blood in the orbit, it's a bony compartment. It's got a finite volume. It's not able to expand because of the bony structures that encase it. So as you bleed into that space, then you're going to build up the pressure. And that's why you start to see this. I mean, I'm going to go through this in a second. This proptosis, the eyeball bulging forward, because it's the only place with less resistance. Otherwise, you're just expanding into bone. So it's called a retrobulbar bleed or orbital compartment syndrome. So I'm sure you've all heard of compartment syndrome. That's where you get a bleed inside a fascial sheath. So if it's related to muscles, where you've got a fixed volume and you're bleeding into it, so you're building up pressure in that space. So it's like a compartment syndrome, but of the orbit itself. There's blunt trauma. So you cause the bleed in the orbit, so not intraocular but intraorbital. Okay, cool. So leading to proptosis, so bulging forward, blah 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 blah. So the way you relieve this, the emergency procedure is a lateral canthotomy and cantholysis. So around the eye, you've got these suspensory ligaments, and on the side, you've got this lateral canthal ligament. And what we need to do is they go in, and then they open it up and they snip. It's like a Y shape. I think they do the inferior one. They snip that ligament, and then it just allows the eyeball to move anteriorly and relieve some of the pressure that's on the eyeball. Because obviously, if you've got blood building up behind and the eyeball is stuck by those ligaments, you're just going to start compressing your eyeball. You're going to cause ischemia to the retina again, and all that sort of stuff. So here we've got two presentations. Now this one, the one on the left looks pretty gnarly, but it's actually not nearly as alarming as the one on the right. Okay, so there are two bleeds. This one on the left, again, is painless. That makes you worry a little bit less. You've got this red patch on the sclera, and it's well demarcated. So just as we hit that iris there, the bleed stops. So we can explain why that is. And there's no effect on vision. Okay, so it's literally just this bleed that seems to stop at the iris. So that one there is called a subconjunctival hemorrhage. So a bleed under the conjunctiva. This one, although I mean it still looks a little bit gruesome, you can see that proptosis. So you can see the severe pain. That's alarm bells. You can see the eyeballs bulging forward. That's your proptosis. Restricted eye movement. So you're starting to think there must be something building up in here to stop that eyeball being able to move. You're affecting vision, and you're affecting the accommodation reflex of the eye, of the pupil. So the response of the pupil to light. So this is our retrobulbar hemorrhage, retrobulbar bleed, orbital compartment syndrome, one of those. I don't think there's a clear distinction. I don't think there's no point distinction between them. There's a bleed behind the eyeball, basically. So if we deal with this one that's pretty innocuous and not that harmful, this subconjunctival hemorrhage. So there's actually a problem with this diagram. So this is from, I think it's from Gray's or something like that. But you see this green line here. That's meant to represent the conjunctiva, and in this, they've drawn it going over the cornea, which it shouldn't. It stops just there where you get to the iris. So when you get conjunctival hemorrhage or subconjunctival hemorrhage, so when you get a bleed under this conjunctiva, it shouldn't pass from what we can see into the iris or into the cornea. It should be well demarcated. Okay, so that's a problem with that diagram there. It shouldn't conjunctiva shouldn't go over the cornea. So when you get a bleed of this nature, it can be idiopathic. If you have, any kind of, so usually, things that can burst small blood vessels are things like retching, vomiting, coughing. It can also, if you've got that in conjunction with any blood thinners, then you're going to be more predisposed to these kind of bleeds from very, very, very small vasculature. So it's bleed under the conjunctiva, rupture of conjunctival blood vessels, and it can be triggered by trauma to the eye, or coughing, anticoagulant use, idiopathic, vomiting as well. So painless, bright red patch. So it looks worse than it is. Conservative management. You don't really need to do anything. You'll just the blood will just sort of dissipate. No really concerns, and no need for any referral. If it's recurrent, then they might need to have their anticoagulation looked at. I'll get to the bottom of why they're vomiting so much or something like that. Retrobulbar bleed, much more worrying. So this is a bleed within the orbit, confined space, not able to expand. The only give you're going to get is pushing that eyeball forward into those suspensory ligaments. So increase orbital pressure from the accumulation of that blood. In the case that we saw, that was caused by trauma. I think it usually is caused by trauma, surgery, orbital fractures. So alongside this, you can be concerned about orbital blowout fractures, that sort of thing as well. So yeah, severe pain, proptosis, we've spoken about this, blah, blah, blah. Management, you need to get rid of that pressure. You need to relieve that pressure. So lateral, so this part of the eye here, we cut here. I don't, but we will. Cut here and then cut one of the canthal ligaments. And that allows the eyeball to actually move forward. But that's exactly what you need to try and relieve the pressure. Relieve the pressure on the eyeball from the building up, the pooling of blood in the orbit. Problems that can cause permanent vision loss, optic nerve atrophy. So any build-up of pressure, whether it's intraocular or it's intraorbital, can compress the optic nerve and cause ischemia to the optic nerve. And that's what you don't want to happen. So that's a common theme running through some of these complications. And yeah, immediate referral to ophthalmology if you see anything like this. Okay, so don't miss it. Don't look like a lemon and refer this, but definitely refer this. Cool. Next one.
So everyone so far is going for urgent CT scan.
Okay, lovely. Yeah, bang on. So 10-year-old child presents with right-sided periorbital swelling, so swelling around the orbit, and they've got fever, so that points towards some, systemic infection. Recent upper respiratory tract infection. So upper respiratory tract, you're thinking sinusitis, inflammation of the sinuses, pharynx, larynx. Examine the reveals, again, this is where it starts to get concerning. Proptosis, so bulging of that eyeball forward. Reduced eye movement, so either something related to the nerves that innervate the extraocular muscles, or probably more likely in this case, the reduced, some kind of physical obstruction to the eye and affecting the vision there as well. So you've got all the things that should make you concerned. So, given the infective history, you might think oral antibiotics, but this is such a severe condition, it's almost definitely going to be IV antibiotics. But yeah, the main thing you need to do, the most urgent thing you need to do is a CT scan, because points towards some kind of infection around the eye, and you need to make a distinction, whether it's orbital cellulitis, so an infection of the structures surrounding the eyeball in the orbit, particularly the periorbital fat, or if it's preseptal. So I'll show you this on what have I said here? Okay, so yeah, well, I'll show you in a diagram in a minute what I mean, but this is an important distinction to make where that swelling is, and the CT scan will reveal this. So what's happened here is that you've had they've had an upper respiratory tract infection, which has now spread to the orbit. So this is the orbital cellulitis. So it's an inflammation of the fat surrounding the eyeball in the orbit. Does anyone know which sinus is most likely the infections come from? Think about your 4 sinuses. Which one do you think is most likely to spread the infection from that sinus to the orbit? For a bonus point. Anything, Luke? Question
yeah,
clear?
not yet.
Just have a guess. What sinus is closest to the orbit? Okay, I'll just tell you. So the ethmoid sinus particularly, I haven't got a picture of it, but the ethmoid sinus, you've only got a very thin piece of bone called the lamina papyracea. So literally like piece of paper in Latin or Greek or something. Very thin piece of bone between the ethmoid sinus and the orbit, so it's very easy for infection to spread. Not very easy, but it's the easiest for infection to spread from that ethmoid sinus to the orbit. So yes, so these are 2 presentations. So here we've got eyelid swelling, so you can see the eyelid swollen, redness, bit of pain, no proptosis, which is a bit reassuring, normal eye movements, which is reassuring, and no effect on vision, which is reassuring. So this is the orbital septum. Okay, so this delineates the orbit from the external structures. So if your infection is outside that septum, we're less worried than if it's inside that septum. For a couple of reasons. For one, the structures outside that septum aren't as integral to your vision. So obviously behind the septum, we're much more worried about any impact on the optic nerve and by extension the retina. Also, when you've got an infection, you've got swelling. So swelling on the outside of that septum is not confined to a fixed space, so it can just move outwards without a significant buildup in pressure. Whereas any swelling, just like the retrobulbar bleed, any swelling in this confined space is going to increase intraorbital pressure. Put pressure on the eye, put pressure on the optic nerve, lead to ischemia, lead to vision loss. Okay, all anatomical, very nice, really. So preseptal cellulitis. So this is the orbital septum here. So that's an infection here, and then you've got orbital cellulitis. So that's an infection behind. Okay, this is anterior to the orbital septum, insect bites, sinusitis, localized infection, not involving the globe or the optic nerve, trauma, insect bites, skin infections, Management is not, unless it's a really complicated case or it's really severe, it's not too concerning. So all antibiotics are fine. Obviously, there is a chance that it can pass behind the septum, so you have to, safety net patients and safety net, and then monitor with a follow-up to make sure it hasn't spread anywhere and the antibiotics are doing their job. Complications, as we said, can progress behind the orbit into orbital cellulitis. And referrals only needed if it doesn't improve with that course. Antibiotics, if it's a kid, most of them are high review, apparently. Just to make sure everything's okay, I guess. Orbital cellulitis, much more concerning. So infection posterior to the orbital septum, so there's an infection in this space here. Secondary to sinusitis or trauma, yeah, so especially the ethmoid. If you have a look at and we're worried about the infection spreading to orbital tissues, affecting the optic nerve. So the actual infection spreading to those extraocular muscles, spreading to the optic nerve, or causing inflammation that's going to compress the optic nerve. So there's a few different mechanisms of injury there. Much more severe condition, so IV antibiotics are needed. And then if any abscesses present, then they need to be drained. So that will usually involve going through probably the ethmoid sinus to locate the abscess and drain it. Complications: cavernous sinus thrombosis. So you've got quite a few of your cranial nerves going through the cavernous sinus. Can't remember exactly which ones, 3, 4, 6, 5A, 5B maybe. So then you can get all sorts of cranial nerve pathologies if you get your cavernous sinus thrombosis. Meningitis and permanent vision loss from ischemia of the optic nerve and then maybe infection of the optic nerve. And then, yeah, emergency referral to ophthalmology and to ENT is needed in that case. So this is the last question, but to be honest, it's more related to vision loss. So I think it's going to be covered in the next session anyway. So, and it's 7:30. So thanks very much for listening to me. Sorry I'm a bit low energy, but hopefully it was helpful. And yeah, I'll finish there. Is that all right with you, Luke?
Yeah, thank you, Paul. That was really good.
No problem. Right, best of luck to everyone.
Yeah, the feedback form should now be in the chat. Let me just double check.
Give me feedback, please. That'd be good.
So yeah, don't forget to fill that out to receive your certificates and discount codes for Teach Me Surgery and Pass the MRCS. Also, be sure to complete the Google form for a chance to win free access to the Geeky Medic surgical flashcards and their OSCE stations. The link for this is available in the chat as well. Our next session will cover ophthalmology, looking more at blurred vision, and that'll be tomorrow at 6:30 p.m. So we'd love for you to join us again. Make sure to follow us on all our social media platforms. The links for these are available in the chat as well, and you'll be able to receive updates on the upcoming sessions via these platforms. We'll also be posting SPAs on our socials for additional practice, so keep an eye out for those. And don't forget to visit our website where you'll find a resource bank with materials not just for this session, but for all other sessions in this teaching series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. To access them, simply create a free account on our learning portal. We hope you found today's session valuable and engaging. So thank you once again for joining us, and we look forward to seeing you at our next session. Thank you, everyone, and thanks, Paul.
No worries. See ya. Bye, everybody.